from Drbeen.com. Welcome to another chat today. Today we are going to talk about the part 3 of the Math Plus protocol. So we have talked about the outpatient management, inpatient management, and today we'll look at the management of the severe and critical patients and the suggestions by the authors of the Math Plus protocol. So let us start our discussion. I am going to, first of all, let's look at the protocol itself, the document, and then we'll start explaining it. So here is the document. Welcome everyone. So we are going to make sure that we are looking at the last part of the Math Plus protocol today, and we kind of finish this. So remember that yesterday we had talked about mildly symptomatic patients on the floor, inpatient management. Today, we are moving to patients with the respiratory symptoms and their treatment. So here, if you look at their criteria, the shortness of breath is present, hypoxia requiring nasal cannula, and the flow of more than or equal to 4 liters per minute, admit to ICU. So this is the section that we are going to look at. So look at this essential treatment, dampening the storm. So that is the important part, that if you look at their basic division of the disease stages, how they look at it is that there is incubation period, then there is symptomatic patient, then there is early pulmonary phase, and then there is late pulmonary phase. So now we are entering the early pulmonary phase, where they are saying that, hey, the patient may have shortness of breath, mild hypoxia, and then as soon as the patient starts requiring more than 4 liters or equal to 4 liters per minute, and the oxygen saturation is going down, that is where anti-inflammatory are being started. And look down here, methylprednisolone. With that, these Enoxaparain, this is the low molecular weight heparin, this is the anticoagulants. So now they have started taking care of the inflammation by steroids plus hypercoagulable state by giving anticoagulants. So that is the mainstay of the therapy. So let's go and see what the therapy looks like. And I hope that everybody is doing good. You are all safe and happy and studying and taking care of yourself and the people around you. So look at this. Essential treatment, dampening the storm. So they're starting with methylprednisolone, 80 milligram loading dose. So the first dose or the first day is 80 milligram. And then the maintenance dose is 40 milligram every 12 hours for at least 7 days. I have seen some therapies that have used a higher dose for 7 days and then 40 milligram for 7 days and then stop. So here the loading dose is higher. And I would mention this once again. They are not suggesting to start the steroids in the early part of the disease. It is actually seen in many studies that if let's say if we have, let me figure out. So here, let's say that this is the disease, and the disease has the initial stage, which is, let's say, outpatient stage, and then inpatient but not ICU, and then critical stage where ICU and ventilation is done. Many studies have seen that when patient is given steroids here, that is, let's say at home, which I'm seeing some doctors, I'm hearing that some doctors in some other countries as well, that they are prescribing steroids right in the beginning. And that is dangerous. And the danger is that as soon as you start giving steroids, you are going to suppress the immune system. And remember, yesterday we talked about it, that almost all cells of the immune system, the innate arm and the adaptive arm, all of that arm gets suppressed by the immune system. So giving steroids earlier would suppress our defense system are attacking system and cause the virus to replicate more. And that can actually intensify the disease and can cause negative outcomes. So the authors are suggesting that there is a specific point where it is important to start steroids. If steroids are given too late, for example, let's say here, if they're given too late, that is also counterproductive because now the damage is done. Now the virus has replicated in big enough of a volume and number that giving steroids is kind of less useful. So this is the time frame where this part, where the patient is transitioning from mildly symptomatic towards severe. That is where a doctor, a clinician has to find out from the labs and from the clinical setting of the patient to say, okay, now I'm going to start steroids. So please, steroids should not be used in disease. So back here and back here. So they are starting the steroids 80 milligram and then 40 milligram every 12 hours, 7 days. Then look at this in patients with an increasing CRP. So now all of us in the cool beans, I think we know that C-reactive proteins are part of the acute phase reaction. And as the inflammation increases, as the immune system becomes overactive, the C-reactive protein levels are going to go up. And so this is one of the labs that we use to see how intense is the inflammation and how intense is the immune system's activity. So see here, let me see if I can make it bigger. In patients with an increased CRP or worsening clinical status, increase the dose to 80 milligram every 12 hourly, then titrate down as appropriate. That means then bring it down. Good. So that is the methylprednisolone. Then with that, so the patient is in the ICU or about to go into the ICU. So then with that, ascorbic acid vitamin C, 3 gram IV every 6 hours for at least 7 days. Here the important note caution with the glucose testing. So look, this is a very, very important thing to keep in mind. I have the study open here, which says influence of vitamin C and maltose on the accuracy of the models of glucose meters. So when the point of care glucose is tested, it is actually possible that vitamin D, higher doses of vitamin C, sorry, I said vitamin D, higher doses of vitamin C can actually mask the hypoglycemia. So if a patient has low glucose level and is also on high doses of vitamin C, the meters may read the glucose level as normal or higher. So you might start managing their glucose downwards, which is already down. And vitamin C is incorrectly showing it as to be high. And that can cause the issue. So it is really not the vitamin C itself. It is the vitamin C's reaction with the glucose testing enzymes, which can then make them not work correctly or work incorrectly and show a higher level of vitamin C. So, high level of glucose. So here is the study. I have put the link out there. So in here, if you see higher concentrations of vitamin C and maltose in blood can lead to false increase in glucose meter reading. They do not lead to falsely to increase glucose. Just the reading becomes wrong, resulting in misdiagnosis of hypoglycemia and potential fatalities. So this is a very important thing. And they have put that over here, that note caution with point of care glucose testing. So I'm sure that in the ICU, glucose test system may be better. Their substrates may be better. Their enzyme specificity may be better. But at least if they're using a glucometer, then the glucose reading can be wrong. Then after that, they're saying do full anticoagulation. So look at the primary activity, primary prescription. What are they doing here? With steroids, they're calming down the immune system. And with anticoagulation, they are now handling the hypercoagulable state. Right? So now look at it. Let's look at the hypercoagulable state and quickly see the drugs that they're going to use. How are these drugs going to be interesting? So I'm going to be coming here. We have talked about this before as well in the hypercoagulable state. So just generally, the cascade for the clotting factors, what we know is that if you start from here, let's say this one, so this is the contact factor or intrinsic factor or the pathway. So here the factor 12 becomes active. We have done that discussion before. That then causes the factor 11 to become active. That causes factor 9 to become active. Finally, all of the pathways usually or will end up at activating the factor 10. Once the factor 10 becomes active, we then know that prothrombin will be converted to thrombin. Thrombin will then convert fibrinogen to fibrin, which are, remember we discussed about it, these are like strands. And then platelets, here these little cute guys, platelets will come and get attached to the injury, and the fibrin strands will kind of tie them together, and that will make a plug. And I hope you remember from the previous discussions that we had said that because this plug here has the fibrin on it, which is acting like sutures, at some point we would like to remove those sutures and fibrin and remove the plug and let the healed tissue re-emerge. And for that, what we do is we take plasminogen, which is another protein, and we activate it. And to activate it, we have tissue plasminogen activators. So these are the substances that are present in the broken tissue, and they are called TPA or tissue plasminogen activator. So if you see, this is a magician here who's activating the plasminogen. When the plasminogen becomes the plasmin, we kind of, we actually put the plasminogen in the clot as well. So once we put that in the clot, then at a later stage, we can make it active, those scissors that would then cut the fibrin and dissolve the clot. So we know this much from our previous discussions. Now what happens is that the drugs that we can use or the drugs that the protocol is offering, let's just very quickly look at those drugs. One of the anticoagulant drug, that means these are going to be the drugs that are going to break the clot. So of course, right, we have the thrombi that are developing in the blood vessels, and we want to break those clots or thrombi. So of course, one drug that can be used is the tissue plasminogen activator. This can be given as an injection, and what it would do is it would activate the plasmin, which will then break the clots. So that is one way of doing it. Another way we can do this is, if you see here, this is the antithrombin here. This blue guy here is antithrombin. Antithrombin is another protein that is present in our body. What it does is it blocks many parts of the clotting cascade. The important part is this one, blocking the factor 10 activation. For that, we have heparin. What heparin does is it combines with the antithrombin and it accelerates the function of antithrombin. Antithrombin then blocks the clotting factors, and so it blocks the whole cascade of the clotting, and the clotting stops. Nowadays, a more reliable way of giving heparin is to give low molecular weight heparin or enoxaparin. And if you would see in the protocol, they would say give enoxaparin. Enoxaparin is actually low molecular weight heparin, but enoxaparin is much more stable, and so it is much more reliable. And what is the reason for that? Heparin, when we give, for example, let's say we give it through the subcutaneous route, heparin can bind to the skin tissue, or heparin can bind to the proteins in the blood. The result is that the dose of heparin that is given versus the dose that becomes available to function are unreliable, are different. So we cannot exactly say how much dose is actually going to become available and how much of the dose is going to get stuck to the skin tissue or to the other proteins in the blood. On the other hand, enoxaparin, which is low molecular weight heparin, does not do these kind of things, or does it at a very low level, so or at a low quantity. So the enoxaparin is a much more reliable drug. You can say that if I gave X milligrams, then X milligram will be available. Good. So enoxaparin is given, tissue plasminogen activator is given. Now, this is a drug, warfarin, that they have not put in the Math Plus protocol. However, because we are talking about the anticoagulants, I thought I'll just discuss that over here as well. So warfarin, this guy over here who's ready to go on a war, to me, he looks like he's so scared that he does not want to go to any war, but I was trying to make him go to a war. So what warfarin does is that, number one, it reduces the potassium reduction. Remember that reduction means gain of an electron. So potassium is reduced to get an electron, then potassium is used for the clotting factors. So warfarin reduces or blocks the reduction of potassium. So here, if you see, there is an electron sitting here and it is crying. Why is it crying? Because it cannot combine with potassium, and potassium is also crying because it cannot be reduced. So the end result is that when the potassium reduction is low, which is an important part of the clotting factors or clotting cascade, then the factor 2, factor 7, factor 9, 10, protein C, protein S, all of those do not work correctly, and that reduces clotting. So warfarin is another drug that I thought I would discover because we are talking about the clotting factors and anticoagulants. So here, the two anticoagulants to be used are TPA and enoxaparin or heparin. So now let's look at their message here. Look, they're saying full anticoagulation unless contraindicated, meaning if the person has any other issues, or they have any other bleeding disorders, or if they're taking some other drugs, or if they have a liver issue, or they have potassium issue. So other than the contraindication, let's say the person does not have the contraindication, then full anticoagulation is done. And on admission to ICU, because after this, you have to really monitor the patient for bleeding issues. So what are they suggesting? Enoxaparin, if you see here, enoxaparin here, 1 milligram per kilogram subcutaneous every 12 hours. Dose adjusts with creatinine clearance lesser than 30 milliliters per second. What they're saying is that look at the renal profile, and if the kidneys are not functioning correctly, then adjust the dose accordingly, because the clearance of the drug will reduce if the kidneys are not working correctly. Then heparin. So this is enoxaparin. Heparin is suggested when the creatinine clearance is lesser than 15. So if the patient has kidney renal issues and the creatinine clearance is lesser than 15, then instead of enoxaparin, give heparin. Alternative approach. So if you don't want to do this, enoxaparin or heparin, then if you see here, this is the recombinant TPA, the tissue plasminogen activator. So give that. So 25 milligram of TPA over 2 hours, followed by 25 milligram of TPA infusion. So this is the basic structure. Now, if what they're saying is, if falling oxygen saturation level, despite respiratory symptoms, should be a trigger to start anti-inflammatory treatment. And so we've talked about it, the steroids. Early termination of ascorbic acid and corticosteroid will likely result in rebound effect. So this is what we talked about yesterday as well, that they have a diagram here. So what they're saying is that if the steroids are started, then do not stop them abruptly or earlier. So if they are stopped earlier, there is a rebound in the infection, and then you have to start them again and bring it back. But that can become a runaway situation, not the infection, the inflammation. So this is the primary back here. This is the primary management. Now I want to go to their full Monte. The full Monte is that all the components that they've been talking about. So look at this. Melatonin, we have not done melatonin, so we will do that next week. Famotidine, vitamin D 2000 to 4000, thiamine 2000 milligram, magnesium, we have not done magnesium or thiamine, so I will cover those next week as well as mechanism of action. Azithromycin, they put that optional. Remember, they have put that as an optional with hydroxychloroquine. So I will actually combine that and not make it optional. Simvastatin. So statin drugs, there is lots of controversy there as well that statins, some people say are harmful, others say they are useful. So these authors are saying theoretical but unproven benefit. Simvastatin has been demonstrated to reduce mortality in the hyperinflammatory ARDS phenotypes. Statins have pleiotropic, anti-inflammatory, immunomodulatory, antibacterial, and antiviral effect. So they feel that there is an effect of statins for inflammation and virus control. So they are saying optionally you can give statins as well. They put remdesivir as optional. I would not put that as optional. I will make it part of the protocol. The role of this agent, we know that remdesivir is IL-6 blocker, and remdesivir is the disruptor for the CCR5, CCL5, and so it has its benefit. Broad spectrum antibiotics. So if the patient is developing secondary infections, so of course the broad spectrum antibiotics are useful. And then look at this one, the point number 13. Maintain euvolemia. What they are saying is that do not give so much volume. So let's say this is the lungs. Because there is injury going on in the lung and there is fluid exuding in the lung, there is congestion that is developing, there is distress that is developing. In this time, if you add more fluids, so let's say this is the fluid. If you add more fluid to the patient, it can actually aggravate the situation with the lungs. So they're saying maintain euvolemia, the volume that comes out of the patient and the volume that goes in, keep a balance there. And that makes sense. And remember, we had that discussion with Dr. Adam Johns as well. Usually what happens is that as the lungs start becoming congested and filled with fluids, the clinician tries to reduce the fluid intake to clear the lungs or start giving diuretics to clear the lungs. But as the volume drops, that causes, number one, the blood pressure drop, and number two, renal integrity starts going downwards. So your bigger problem in the COVID-19 patients to manage who are in the ICU or problems are the following. Number one, you have to figure out how much oxygen to give and how much oxygen not to give, and to keep them properly oxygenated while their lungs are damaged. So that is one issue. Second issue is their volume, how much volume to add or how much volume to hold. That is another issue that you have to look at. And the third one is how much immune system to dampen and how much to leave working. So do you give steroids? Do you give a lot of steroid? What point do you give steroids, and so on? So these three basic mechanisms are something that you have to look at when you're managing the patients. So going back here to the discussion, they're saying maintain euvolemia. This is not non-cardiogenic pulmonary edema. So they're saying that this is not a pulmonary edema that is developed because of some other issues than heart. And yes, this is correct that this is because of the viral damage, but it still is not that kind of a edema that normally occurs. So due to the prolonged symptomatic phase with flu-like symptoms, patient may be volume depleted. Cautious rehydration with 500 milliliter bolus of lactate ringer may be warranted, ideally guided by non-invasive hemodynamic monitoring. Diuretics, look, diuretics should be avoided unless the patient has obvious intravascular volume overload. Make sense? And finally, early norepinephrine for hypotension. Remember, in the septic shock, the patient, what is the septic shock? The major part of the septic shock is that the blood pressure drops below 90 systolic and I think 50 diastolic. So there is a there is a risk, or actually a very big chance of organ damage because of low flow, low oxygenation, low nutrition. So when the patient is going in that kind of a shock, then norepinephrine is needed to make sure that the hypotension is controlled. Good. So this is the ICU management. What are you seeing here? Yeah, so 50 to 60 diastolic. So what are you seeing here is they are trying to control inflammation, and they are trying to control hypercoagulable state while they are trying to control the reactive oxygen species levels and blood volume, and they are trying to control the viral replication. But if you see here in the ICU, they're not saying give hydroxychloroquine here. They're not saying that give ivermectin here, although I've seen some ICUs doing it. But generally at this stage, patient needs more help fighting with or curing the damage and supporting the patient while the damage is healed compared to just fighting with the virus. Okay, so this much, if this is interesting, I want to continue on. They are saying here, now if the escalation of respiratory support is needed, so if the patient continues to become aggravated, then what do you do? So number one, accept permissive hypoxemia. And what does that mean? Keep oxygen saturation greater than 84. So do not put the patient on ventilator if you're seeing the patient is, let's say, at 86, 87. Don't rush to the ventilator. Accept it up to 84. Accept it that it's okay. Hold on from taking the patient to a ventilator. Follow venous lactate and central venous oxygen saturation. That is fine. Nasal cannula. So oxygen flow now is 1 to 6 liter per minute. High flow nasal cannula up to 60 to 80 liter per minute. Trial of inhaled Flolan or epoprostenol. So what is that? So let's look at that very quickly here. This is that. This is my quick diagram for epoprostenol. So what that is it is prostaglandin 2 substance. It is produced in our body as well. Yesterday we talked about it. Remember the arachidonic acid from the phospholipid? We actually did that here. Let me just quickly see here. So we did this discussion yesterday that from the phospholipids of our cell membrane, we make arachidonic acid. From that, we have cyclooxygenase or lipoxygenase, which makes prostaglandins or leukotrienes, correct? So we are talking about the prostaglandins, PGI2. So here, PGI2, when given as a drug from outside, it is called epoprostenol. The function of the PGI2 are two that are interesting. Number one, it stops the platelet. See, it is standing on a platelet and not letting it work. It stops platelet activation. So when the platelet activation is stopped, then this hypercoagulable state does not occur, or it reduces, because platelets cannot come together and they cannot make plugs because platelet activation is suppressed. Secondly, it also causes some vasodilatation as well. So the prostaglandin I2, actually prostacyclin or epoprostenol is given. So back here, so they're saying that try to give epoprostenol. Why? Again, they're trying to fight with the hypercoagulable state. Attempt proning. I have seen with my patients that asking them to prone, even when the mild stage is there, that is so beneficial. And we have had that discussion many times. The benefit of the proning is this. So let's say when you are lying on your back, so let's say this is a person lying on their back, heart of the person will fall on the lungs, correct? It would rest on the lung and it would press the lung tissue, which reduces the volume of the lung tissue available for oxygenation to become less. Similarly, if you are lying on your side, so let's say this is a person who is lying on their side, here is a pillow, the heart would once again fall on the lung below it because of gravity, And again, that part of the lung below the heart will be pressed. So both of those positions cause the lung volume to reduce or have less lung volume available for respiration. On the other hand, when a person is prone, and let's see if now I can make a prone person. So let's say this is a bed. And on this bed, what you do is you put the person in a way that you bring their head a little bit outwards, have them lie on their back. And so they're lying on their back. Now what would happen is that the heart would actually fall on their sternum in the chest. And that would allow the lungs to open up because the heart is not pressing on the lung anymore. And that causes easy breathing. So prone position, the patients who talk with me about the COVID-19, I ask them even at home to do prone positions and breathing with that. So attempt proning, cooperative repositioning proning, then intubation by expert intubator if the stress of the respiratory system continues to increase. And see here, try to avoid intubation as much as possible. Volume protective ventilation. So remember yesterday we talked about it, that the problem is not that the lungs are not inflated. So don't try to press too much pressure in the lungs. Don't try to inflate them like a balloon. They're already inflated. So just help with the breathing, help with the ventilation, but don't try to push extra pressure. Keep driving pressure lesser than 15 centimeter. And then moderate sedation. Why do we give moderate sedation? We sedate the patient because the patient is now going to start fighting with the ventilation tubes. They will become aggravated. They'll become anxious. Their heart rate would go up. Their tachycardia would go up. And so the whole thing becomes a big issue for a patient who is conscious. So patient is sedated so they do not fight it. Some patients would just try to pull the tubes out. So we try that they do not have self-extubation. And then the last two lines, they have actually said them here. I think they just typed them incorrectly once more. Trial of inhaled Flolan, we have that here. And prone positioning, we have that up here as well. So this is if the patient continues to deteriorate, then what have they added? They have added more oxygen to the patient. They have started giving a prone position. And they have added one more antiplatelet drug or anticoagulant drug to fight with the hypercoagulability. Good so far. So what have they done so far in this? They've given steroids, they've given anticoagulants, they've given oxygen, they continue to give ascorbic acid, and now they're trying to prevent the patient from ending up on a ventilator. Then, salvage treatment. So salvage treatment is if the patient continues to become even more deteriorated, then what they're saying is that do plasma exchanges. So plasma exchanges that you bring some plasma in, you can take some plasma out. So the new plasma that comes in hopefully brings in some fresh nutrients, plus it doesn't have that much of the issue, the cytokines and the chemokines that the patient has produced. So the plasma exchange is helpful to reduce all those chemokines present in the body. Then look at this, high dose corticosteroids. So if you keep an eye on this whole protocol in the ICU, once again, you would continue to see they would do these three things. Number one, reduce the inflammation. Number two, reduce the hypercoagulable state. And number three, make sure that the oxygen and blood volume are maintained. So here, high dose corticosteroids. Then do you see here tocilizumab? So we talked about it, IL-6 inhibitor. So tocilizumab is given. Or ciltuximab, which is also an IL-6 inhibitor. So I misspoke a few minutes ago about the remdesivir, that it is an IL-6 inhibitor. Remdesivir is that adenosine analog in the RNA, which helps disrupt the viral replication. Convalescent plasma, the role and timing of the plasma are uncertain, but still convalescent plasma is useful. Then CVVH with cytokine absorbing filters. So what that is I think it is what they do is they take, so it is a venous hemodialysis, or what is this? Let me show you here. So what they do is this. They take the patient, so let's say this is the patient. Of course, in the ICU, patient will not be standing. So imagine this patient is lying. What they do is they take blood from the vein, bring it into a machine that would take the blood, then they would add some infusions to it. They'll do some filtration of the blood, and then they would bring it back and inject it back into the vein. So there could be veno-arterial process or veno-venous process. There could be a process with veno-venous oxygenation only, or it could be veno-venous oxygenation plus dialysis only, or there can be a mixture of both of them. So here they're saying, once again, if you see, they're trying that the patient's blood is cleaned out. So they have put cytokine absorbing filters. So again, they are trying to reduce the chemokines and cytokines which are coming from the inflammatory system. And finally, ECMO. ECMO is where they would take, again, from the same patient, let's say, they'll bring the blood out and they would oxygenate the blood inside that machine and bring the blood back. Here, the machine also acts as a heart. So the pumping of the blood is also done by the machine, and oxygenation of the blood is also done by the machine. So the heart and the lung of the patient, even if they are not working correctly, they can still support the patient on ECMO. ECMO machines are not available everywhere in all hospitals, but are very interesting. They have their side effects as well that needs to be considered. So if you see here, they're saying ECMO for lesser than 6 years of the patients, no severe comorbidities, organ failures. Unlike typical ARDS, patients do not progress into a resolution phase. Rather, patients with COVID-19 progress to a severe fibro. This is a very important part, and this is what worries me. I've been looking after some patients who are admitted, so not as a doctor, but as their relative. So the problem with the ICU or problem with the patients on ventilator is the following. So let's say here are the lungs of a patient who is on the ventilator. Now these lungs are slowly getting damaged, correct? We've talked about it. And we've talked about it that pneumonia normally can go into two directions. So let's say if this is an alveoli and it is congested, and this is another alveoli which is congested, one pathway is resolution. Resolution is where the debris, the trash, the congestion is cleared out, normal tissue is restored, and a functional alveolus comes back to normal. So this is called resolution. Many times pneumonias resolve and we end up with our normal functional tissue. However, in some cases, pneumonia does not resolve. Instead, it becomes organized. Organized means that the fibrous tissue over here develops, then scarring develops, and this whole thing just becomes a solid mass with a scar in it, and then it contracts. So the end result of that is that imagine if a patient is on ventilator for 40, 50, 60 days. His lungs are now so much damaged and they are so much fibrosed that the lung tissue has become scarred and it has become mostly non-functional tissue. Even if such patient is conscious on, let's say, ventilator and is alive, it is possible that when they come off of the ventilator, they have developed this baby lung issue. Somebody commented here, absolutely. Plus, they have developed a lots of non-functional tissue in the lung. So how will they breathe? And this is what we call ventilator dependency. That if you take the ventilator out, they cannot breathe very well because the functional tissue is not there anymore. And that is the problem. So this is why doctors, when they put a patient on the ventilator, they try their best that the fibrosis and scarring and tissue damage does not occur. And they try that by giving steroids and other anti-inflammatories so that the fibrosis or organization does not occur. So here, that is what they're talking about. They're saying that this is unlike typical ARDS. Patients do not progress into resolution phase, meaning the pneumonia does not resolve. Rather, patients with COVID-19 progress to a severe fibroproliferative phase and ventilator dependency. So that is the problem. And then ECMO is in these patients would serve very little purpose. So now what they're saying is, even if you put these patients on an ECMO, so let's say you put a machine here, ECMO, that can take their blood out, oxygenate it, give it back to their body. But the problem is that whenever you'll take the ECMO out, their lungs are still damaged. How would they independently have a functional lung other than a lung transplant or rehabilitation of the lung over a long period of time? So that is a problem with the folks who can end up on ventilators for long periods of time. Again, there are people who end up on ventilator and then they come back and they recover and they partially have functional lungs and they're okay, but there are people who would have severe lung damage. Then the treatment of the macrophage activation syndrome. We talked about it yesterday as well. So look, this is the macrophages that have gone nuts and that are now producing a lot of inflammatory behavior. So let's see where these are. We talked about it yesterday here. So remember, we are talking at this stage. The macrophages are producing lots of interleukin 1. Macrophage can produce interleukin 1, monocyte can produce interleukin 1, dendritic cells can produce interleukin 1. With that, some B cell and T cell can produce interleukin 1 as well. Interleukin 1 would do two things. Number one, it would go to liver. And remember, it would cause the acute phase proteins to come out. That is one. It would work on hypothalamus and cause fever. So hypothalamus in the brain, it would cause fever. And sorry, I said it works on the liver. It does not work on the liver. It actually works on the other immune cells. And what it would do is this. If this is a blood vessel, the immune cell diapedices, we talked about it yesterday, that the cell to stop in the blood vessel, then to get out of the blood vessel, and then to go to the area of infection and create a fight over there. This process of diapedices is walking by a cell. So coming out of the blood vessel and going to the infection area, diapedices, interleukin 1 causes diapedices. Just like interleukin 6 does that, just like tumor necrosis factor does that, and many other, but interleukin 1 does it too. So here, if you would see, in this situation, they are reaching a point where the situation is so bad now that they may need to further downregulate the immune system. So they're trying to do everything. They've given steroids, they have given IL-6 blockers, they have given viral replication blockers like remdesivir, and now they've given anticoagulants. And now if you see here, what are they doing? First of all, this appears to be driven, the top line, the macrophage activation syndrome appears to be driven by SARS-CoV-2 induced inflammatory activation and increased interleukin 1. We just looked at interleukin 1, that would cause a lot of, number one, fever, and number two, activation of the immune system or chemotaxis of the immune system, especially diapedices. So if ferritin level of greater than 4,400 nanogram per milliliter is considered diagnostic of MAS. We talked about why ferritin level increases in the acute infections. One, that the macrophages would release more ferritin, and number two, ferritin is also built as a acute phase protein. So ferritin is a good indicator that there is an acute infection and inflammation going on. And especially macrophages are active because ferritin can come out of macrophages. And if macrophages are active, they would produce more ferritin, and we can then measure that ferritin to see if the macrophages are active. So ferritin levels would tell us that the macrophages are active. Then AST, ALT, and increasing CRP. So these are all the enzymes that show the damage to, let's say, liver, and then acute phase protein is CRP. Once again, look how they're handling high-dose corticosteroids. What is they doing here? 120 milligram every 6 to 8 hours for at least 3 days. Then, according to the ferritin, they would adjust it. Then consider plasma exchange. Then consider Anakinra, which is IL-1 binding blocker. So what it does is it inhibits IL-1 binding to the interleukin-1 type receptors. So it is an IL-1 receptor blocker. And so what is where would it work? IL-1 receptor blocker. So let's say here is a macrophage. It is active. There is a macrophage activation syndrome. Macrophage has become very, very angry. It is producing a lot of interleukin-1. Interleukin-1 is going to work on all other cells of immune system and ask them, recruit them to come in to the fight area. And so we don't want that. We don't want B cells to come there, T cells to come there, more macrophages to come there, more neutrophils to come there. So we are going to block the interleukin-1 receptors. And Anakinra is that drug. Anakinra. So if you see, what are they doing here? In the whole of this treatment, they are either, so let's say this is a macrophage, this is a T naive cell, then this is a T helper 2 cell, this is a B cell, this is a T helper 1 cell, this is a cytotoxic T cell, T cytotoxic cell. Then there may be T helper 17 and there may be Treg, right? So this is the immune system's picture. They are either in a blanket covering, blocking the whole immune system by steroids, or they are shooting at individual targets and trying to block them, either with the IL-6 blocking or with the IL-1 blocking. So Anakinra is given, plasma exchange is given, and then if we continue on, monitoring. So what are we going to monitor? So I think now you can know that we will monitor all acute phase proteins. We will monitor the enzymes that are released from damaged tissue cells. So if you see here, PCT, CRP, IL-6, BNP, troponin. So I think you can give it a read, but have the monitoring. In patient receiving IV vitamin C, the AccuCheck POC glucose monitor will result in spuriously high blood glucose level. See, they keep saying it because patient might be okay for your management, but if we thought that their glucose level is more while they were actually hypoglycemic and we try to further reduce their glucose level, we might actually cause so much hypoglycemia that the patient might die with that. So therefore, a laboratory glucose is recommended to confirm the blood glucose levels. Monitor their QT intervals, and especially when you're giving hydroxychloroquine and other drugs, for example, azithromycin, magnesium. Magnesium can cause torsades. We have not talked about magnesium before, so we'll talk about it next week. No routine CT scans. So CT scans are also not suggested by the radiology organizations too. Chest X-ray and ultrasound may be useful. Follow echo closely. Patients develop a severe cardiomyopathy. And we have talked about that in the hypercoagulability discussions. And finally, post-ICU, patient safely comes out of the ICU, goes home. So what do you do? So comes back to the ward and you start again enoxaparin, which is once again low molecular weight heparin, methylprednisolone, low dose, vitamin C, melatonin. That is it. That is it. I am so happy that we could go over it. I think if I can boil it down, the whole thing, then the basic mechanism is very, very simple. They are in the early stages outside the hospital. Take hydroxychloroquine, zinc, vitamin C, vitamin D, quercetins, ivermectin, azithromax, doxycycline. So that is all outside. When the patient comes to the ward, then first start with the oxygen plus hydroxychloroquine or remdesivir or other IL-6 blockers or other things. And finally, when the patient is in ICU, they are looking at primarily oxygenating the patient, then hypercoagulable state management by giving anticoagulants, and then the immune system management by giving steroids and some focused immune system modulators. That is it. I love this protocol. There are some parts that we can change, and we have discussed that in our previous 2 talks about this protocol. So I think this is what we have. I hope it makes sense. I would request you to give it a look as well. I have put all the links out. So give it a look, give it a read. If you're a medical professional, medical student, nursing student, nurse professional, please, it would help at least have you be educated. And if you are a layperson who is not a medical professional, I think it is fascinating to see that what is it that doctors are trying to fix, and that is runaway immune system, and then oxygen for the lungs. That is a primary method that they are trying to use. Good. So I hope that this makes sense, and we will continue. So tomorrow is my off. On the next week, those drugs that are here but we have not talked about, we will talk about that. For example, we'll talk about steroids a little more. We'll talk about vitamin K. We will talk about aspirin. We'll talk about magnesium, melatonin, and a couple of more drugs. So we will kind of make this whole Math Plus even more understandable by talking about those drugs that we have not talked about before. So thank you very much for your time. Once again, please like, subscribe, and share. I can tell you truthfully that the viewership on YouTube has gone down to half. So I think that YouTube is not putting our videos out to others, which is fine. We are on that platform. So if they decide to do that, then so be it. But I think some of this content is useful. So if you like it, if you appreciate it, please like, subscribe, and share. Thank you very much, and talk to you on Monday.